both Uma and Shakrajit have joined, so we can start. Mehul?
Yes, sir. Yes, sir.
Okay, fine. Good morning. Today we have two journal club presentation. One by Dr. Uma Murmu, who is a second year junior resident at IPGM SKM Hospital, and secondly by Dr. Shakrajit Maiti, who is a second year junior resident at Howrah District Hospital. So, Uma, can you share your screen and present?
Hello, am I audible, sir?
Yes, yes, you're audible.
Okay. Good morning, all of you. I'm Dr. Uma Murmu from IPGMER, presenting an article on randomized controlled clinical trial of combined port site infiltration and intraperitoneal irrigation with bupivacaine on post-operative pain after laparoscopic cholecystectomy. The article is publishing on Indian Journal of Surgery, volume 85. Laparoscopic cholecystectomy is the most commonly done procedure for gallstone diseases, as we know. However, pain is one of the most important reasons for overnight stay following the surgery. In this regard, it becomes essential that pain management is done adequately to relieve the patient of post-operative pain and allow for early discharge of the patient. The aim of the study is to evaluate the effect of infiltration of bupivacaine at the laparoscopic port site and intraperitoneal wash of gallbladder bed with bupivacaine on postoperative pain after laparoscopic cholecystectomy in terms of visual analog scale score, use of rescue analgesics, and hospital stay duration. The study design was analytical. Period of study was 6 months from January 2022 to June 2022. The study populations are the patients undergoing elective laparoscopic cholecystectomy in 60 patients. The inclusion criteria and exclusion criteria. The inclusion criteria is first 60 patients undergoing elective laparoscopic cholecystectomy in the study period, and the exclusion criteria are patients with comorbidities, pregnant ladies, and immunodeficient patient. Material and methods. The patients were prospectively randomized into two groups by simple random sampling. First patient in the randomly prepared operation list on the previous day by another doctor was put into bupivacaine group and next in the placebo group and so on. An anesthesiologist administered the general anesthesia to all the patients in the same protocol, and the surgeon administered the bupivacaine and or placebo to the patients. The placebo group received a saline wash into the gallbladder bed. The bupivacaine group received an intraperitoneal wash of gallbladder bed with 30 cc of 0.5% bupivacaine, and another 20 cc of 0.5% bupivacaine was infiltrated into the port sites. Pain was assessed at 1 hour, 2 hour, 6, 12, and 24 hours after surgery using visual analog scale score. Acetaminophen infusion was used as a rescue analgesics, which was noted, and duration of the hospital stay were also recorded for each patient. So coming to a visual analog score, it is usually a horizontal line with word descriptors at each end and around 10 centimeters in length. The patient marks on the scale the point that they feel represents their perception of pain on a scale of 0 to 10. 0 indicates no pain and 10 indicates very severe excruciating pain. Mild pain 1 to 2, moderate pain 3 to 4, severe pain 5 to 6, very severe pain 7 to 8, and very severe excruciating pain 9 to 10 on the scale. The statistical method was used, that is, analysis was done using IBM SPSS statistics. This is a software package. This is a software program using for research studies. Coming to the result, the range of population in both groups. In the bupivacaine group, the average mean, the mean age was 36.97 years with a standard deviation of 11.346. In the placebo group, the mean age was 38.43 with a standard deviation of 14.27 years. In the bupivacaine group, 24 women and 6 men. In the placebo group, there were 21 women and 9 men. This is a chart showing the comparable comparison in terms of USG finding, intraoperative finding, and intra-op and post-op complications in both the groups. There were significant decrease in the visual analog scoring at 1, 2, and 6 hours post-operative period in patients in the bupivacaine group. The p-value was less than 0.001. And at 12 and 24 hours post-operative period, there was no significant difference in the visual analog scoring, scale scoring of pain between the bupivacaine and the placebo group. The p-value was more than 0.05. This is the chart showing the visual analog score in the bupivacaine group and the placebo group. Here, as we can see, in the first hour, mild pain was there in the bupivacaine group in 26 patients. In the second hour, mild pain in the 26 patients, moderate pain in 4 patients. In 6 hours, mild pain in 16 patients, moderate pain in 12 patients. In 12 hours, 26 patients, mild pain and moderate pain was in 2 patients. This is use of the rescue analgesics. The use of rescue analgesics was significantly less in the bupivacaine group as compared to the placebo group. The p-value was less than 0.0001. As you can see, only 27 patients received only 3 patients received rescue analgesic in the bupivacaine group, and 26 patients received analgesic in the placebo group. Post-operative day of discharge was significantly earlier. The p-value was less than 0.1 in bupivacaine group of patients. As we can see, in the bupivacaine group, 27 patients are discharged on post-operative day 1, and only 2 patients are discharged on post-operative day 1 in the placebo group. Coming to the discussion of the article, this study demonstrates that irrigation of the gallbladder bed with bupivacaine and port site infiltration of bupivacaine decreases post-operative pain in the patients undergoing laparoscopic cholecystectomy. And this may be explained by the fact that both the visceral and the somatic pain components get taken care of by this combined approach. In similar studies, pain was more intense in the saline group at each point of time. Significant difference between the bupivacaine and placebo groups were present for up to 8 hours. Analgesic consumption was significantly lower in the bupivacaine group. Significantly fewer patients in the bupivacaine group, 32.5% had severe pain. In the same study, 40% patients in bupivacaine group require a supplementary analgesic compared to 85% in the control group. Another study evaluating postoperative shoulder tip pain as recorded on visual analog scale found that pain was significantly less in bupivacaine group compared to saline group. Few contrast report. In few studies, A few studies did not report effective pain relief with bupivacaine as compared to placebo. These studies, however, used 100 ml of 0.15, 80 ml 0.125, and 20 ml of 0.25 bupivacaine into subdiaphragmatic space at the end of the surgery. So, three possible explanations. The total dosage of the bupivacaine was very low. Drugs was given only into the subdiaphragmatic space, which may have blocked shoulder pain but not the visceral pain. And drug was given in low concentration and may have distributed into the peritoneal cavity with consequent loss of potential analgesic action. Another study found that reduction in abdominal pain at 6, 12, and 24, 30, 36, and 48 hours was insignificant. This might be due to the fact that bupivacaine is more effective in the early hours, not in the late post-op hours, which was not evaluated in this study. So the conclusion which I'm getting is that combined port site infiltration and intraperitoneal irrigation of the gallbladder bed with 0.5% bupivacaine after laparoscopic cholecystectomy significantly decreased the early postoperative pain and may explain the reduced use of rescue analgesics and earlier discharge of the patient in the study. Thank you.
So it's a good paper suggesting that infiltration of bupivacaine and intraperitoneal bupivacaine really helps. In fact, I have the experience of undergoing lab chole last week. So my wound was infiltrated with bupivacaine, and it was really that in 24 hours there is no pain, but the rescue analgesic was continuing. They also give paracetamol and diclofenac as analgesic, so it was almost zero pain. But if the bupivacaine works so well, then you can avoid using these NSAIDs and acetaminophen. Okay, there are a lot of studies, but point is the visceral pain is usually not very significant. The pain that occurs out of viscera is the shoulder pain because of diaphragmatic irritation. And there are a lot of studies that if you do intraperitoneal instillation of bupivacaine, the shoulder pain will be less. Because the intraperitoneal infiltration is just for preventing shoulder pain. As such, the visceral pain is not a somatic pain. You don't have, most of the pain is in the port sites.
Yes.
Okay. So is there a study comparing only port infiltration versus port plus intraperitoneal and the outcome? Is there any study like that?
Only port site.
Because it's a combined study. It's a port site plus intraperitoneal infiltration, irrigation. Because see, if you irrigate only about 20 ml of bupivacaine in the peritoneal cavity, you see that the volume is not very high. It hardly matters. 20 ml bupivacaine in the peritoneal cavity may not be a good volume to cause analgesia in the whole of this peritoneal site. Okay. But yes, the infiltration of local, you see, in most of the cases, in large laparoscopic incision also now you use bupivacaine, and it really helps in the post-op period, in the at least up to 24 hours.
Yes.
Okay, then this is a good paper. This is a paper which is a concept changing, where you can use this ancillary method for pain relief. Okay, so I think.
Yes, sir. Good morning, sir. Hello.
Yeah. Yes, please. Ronit, you have any experience of this type of study in SSKM?
No, sir, I don't have any experience on this, but we regularly infiltrate the port site sometimes with bupivacaine or lignocaine, but it causes reduction in pain post-operatively.
Do you use analgesic also post-op?
No,
because
sir,
this
we
study
use,
we are
we
trying
use,
to show that most of the patient in bupivacaine group does not require the rescue analgesic. This is given on demand.
Okay, but we generally use paracetamol regularly, but in yeah, but additionally we use the port side infiltration, but we didn't do this study.
Yeah.
I think it will be a very good presentation if you can avoid the NSAIDs used post-op.
Yeah.
Hello.
Okay, Shankarajit, you can share your screen and start presenting.
Good morning, sir. I'm Shokrit
Yeah.
Maiti from first year postgraduate trainee, Howrah District Hospital. Today, my journal presentation topic that effect of axillary dissection versus no axillary dissection on 10-year overall survival among women with invasive breast cancer and sentinel node metastasis. It is a Z11 randomized control trial. It is published on 2017-18 July. On introduction, the extent of breast cancer surgery was based on the Hostilian concept of breast cancer as a locological disease that spread via the lymphatic system was cured by resection. Now, axillary lymph node dissection, long used to identify women with axillary nodal metastasis, was replaced as a staging procedure by the less morbid sentinel lymph node dissections. In this Z11 trial, was designed to determine whether sentinel lymph node dissections yield survival more outcome that were non-inferior to the axillary lymph node dissections. Objectives that 10-year overall survival of patient with sentinel lymph node metastasis treated with best conserving therapy and sentinel lymph node dissections along non-inferior the women treated with axillary lymph node dissections. Study type, multi-center randomized control trial, clinical trial. Study time, May 1990 to September 2016. Study site at both academic and community medical center, 115 sites. Sample size, 891 participants. Method, patient character, adult woman with historically confirmed invasive breast carcinoma, size 5 centimeter or less, no palpable adenopathy, sentinel node containing metastatic breast cancer. Eligible criteria that women with clinical T1 or T2 invasive breast cancer, no palpable axillary lymph adenopathy, 1 or 2 lymph node containing metastasis. Patient not included in this trial, those who are undergoing mastectomy without radiation, patient treated with partial irradiation, patient receiving adjuvant chemotherapy, those treated with radiation with prone position, whether low axillary not treated. Study design, stratification done based on age, hormone status, tumor size, patient with 1 or 2 sentinel node metastasis, no axillary third field irradiation or completion axillary lymph node dissections. Patient assessment. For disease recurrence with a history of physical examination every 6 months for the first 36 months and then yearly thereafter. Annual mammography was required. Other testing was based on individual symptom or by the investigator's preference. Study endpoint. The primary study endpoint was overall survival. The primary study endpoint was the overall survival, which defined as the time from the randomization until the death for any cause. Disease survival, which was defined as the time from the randomization to the death or the first breast cancer recurrence. It is a secondary endpoint along with the locological recurrence. Intervention, all patients had planned lumpectomy, tangential whole breast irradiation, and adjuvant systemic therapy were given. Third field irradiation was prohibited in this trial. Study analysis. The study design hypothesis that overall survival would be 80% at 5 years for the optimally treated women. The sentinel lymph node dissection along with the sentinel lymph node dissection along the group would be considered clinically non-inferior to the axillary lymph node dissection if the 5-year survival rate 75% or greater, the hazard ratio was 1, if greater, and the hazard ratio was 1.3 or less. An estimated 500 deaths were needed for the study to have 90% power, according to the Cox regression model. Enrollment of the 1900 patients in 4 years with a minimum follow-up period of 5 years initially planned. The trial closed early because of low accrual rates. The protocol specified that the patient was to be followed minimum for 10 years. It is a randomization flowchart how the patient treated. There is total number of 891 randomized patients. It is divided in two groups. 446 randomized to receive sentinel lymph node dissections. Among them, 436 received sentinel lymph node dissections as a randomized trial, and 10 withdraw prior to the surgery. Among them, 74 lost to follow-up, 3 discontinue, 2 refuse after randomized surgery, but 2 refuse after randomization but prior to surgery. 1 option for alternative method. 400 among 891 patients, 445 patients randomized to receive axillary lymph node dissections. Among them, 420 received axillary lymph node dissection as randomized. 25 withdraw prior to the surgery. Among them, 92 lost to follow-up, 2 discontinue, 1 refused after randomization, 1 concept obtained after the patient register. Statistical analysis. Kaplan-Meier survival curves for overall survival was compared using the log rank test for non-inferiority. The adjusted hazard ratio was calculated using Cox regression analysis. Patients who were lost to follow-up, missing data was censored at the time of their last follow-up. Comparison was done among the 4 groups of patients. Hormone receptor positive treated with axillary lymph node dissections, hormone receptor positive treated with sentinel lymph node dissections, hormone receptor negative treated with axillary lymph node dissections, hormone receptor negative treated with axillary lymph node dissections. It is done using a log rank test. Statistical analysis. Data quality ensured by the review of the data by the Alliance Statistical and Data Center, and the study chairperson follow the Alliance policy. Each data analysis formed with a two-sided 0.5 significance level and 90% clears. Search version 9.4 were used for the all analysis. Result. Patient characteristics. Patient enrollment began in May 1990 with a planned accrual of 900 patients and closed in December 24 due to lower expected event rate. There were 891 patients randomized from the 115 institutions, 35 withdraw consent. Treatment result. Fewer lymph nodes were removed in the sentinel lymph node dissections than in axillary lymph node dissections. Micrometastasis seen, that is less than 2 mm, was identified in the sentinel lymph node 164 patients in the sentinel lymph node dissections, and micrometastasis seen in 137 patients in the axillary lymph node dissections. 27.3% patients in axillary lymph node dissections had macrometastasis in non-sentinel nodes removed during the axillary lymph node dissections. Overall survival. Adjuvant systematic therapy delivered 423 women in sentinel lymph node dissections and 403 women in axillary lymph node dissections. Women received radiation therapy 277 in the sentinel lymph node dissection group and 263 women in axillary lymph node dissection group. 18.9% received protocol prohibited nodal-free radiation. 11 received no radiation. Median follow-up of 9.3 years. There was 110 deaths, 51 in sentinel lymph node dissection and 59 in AL-ending lymph node dissections. There is a graph for overall survival. Here the hazard ratio less than 1.3. There is 51 event in sentinel lymph node dissections during the median years 9.3 years, and 59 event in axial lymph node dissections. Disease-free survival, that is the 10 years disease-free survival was 18.2% for sentinel lymph node dissections and 72.2% for the axial lymph node dissections. Only one nodal recurrence observed in sentinel lymph node dissections. No recurrence ordered in axial lymph node dissections. Is a graph showing disease-free survival. Here also the hazard ratio is 1.3, less than the 1.3. Because the p-value 0.32. Please previous the slide. Mehul, please previous slide. There are the 73 events sentinel lymph node dissection group in a median follow-up 9.3 years, and the 82 events in the axial lymph node dissection group. During the median follow-up period 9.4 years. In JD11 randomized trial, the clinical demonstration that sentinel lymph node dissection did not result inferior to the axial lymph node dissection in overall survival outcome with T1 or T2 node negative breast cancer and 1 to 2 positive sentinel lymph node treated with breast conservative therapy and adjuvant systematic therapy. We can avoid axillary lymph node morbidity without decreasing cancer control. There is no significant difference in disease-free survival between patients treated with sentinel lymph node dissection and axial lymph node dissection. This management should not be applied on the patient having positive palpable node, metastasis in more than 2 sentinel node, patient foregoing whole breast irradiation, those who treated mastectomy without radiation, patient receiving neoadjuvant therapy. There is some limitation of this study. Not all biological subtype can be analyzed for some variation in the locological treatment, low accrual rate, low event rate. Conclusion that there is no significant difference, 10 years overall survival between sentinel lymph node dissection and axial lymph node dissection in a woman having among women with T1 and T2 invasive primary cancer, no palpable axial lymph adenopathy, and 1 or 2 sentinel lymph node containing metastasis. Similar study that author Venerosi and shows that the random in his study he shows that the sentinel lymph node biopsy is safe and accurate method of screening the axillary node for the metastasis in a woman with a small breast cancer. Next. In the Amaros trial, it shows that axial lymph node dissection and the next. In the Amaros trial, it shows that the axial lymph node dissections and the axillary radiotherapy after a positive node provide excellent and comparatively axillary control for the patient with T1 to 2 primary breast cancer with no palpable lymphadenopathy. Thank you, sir.
Okay, if you go to the Amaros trial, these are the patients you are talking of who has breast conserving surgery. Whole 891, they're all patient of BCS, no?
Hello.
These are the patients. These 891 patients, the two group, both underwent BCS. So in BCS, the breast radiotherapy is mandatory. And in that case, we are saying that the axilla was not given radiation, even in SLND positive group.
No, it shows that if the axillary irradiation done, the breast patient was not included in the study.
Okay, so all the patients who are 436, they have only SLND and the lymph node positivity was 1 or 2. And you are saying that how many are only micrometastasis?
No, 1 or 2. Micrometastasis in the SLND, there is micrometastasis.
I think majority is micrometastasis.
Yes, sir. Micrometastasis for 164% for for SLND group, and the axillary lymph node dissection 137.
Because in Amaros trial, they have compared sentinel node positive, they compared this patient in the post-op with radiotherapy or ALND. And they are trying to say that the outcome is almost comparable, but the morbidity is less if the patient has axillary radiation versus ALND. But
Yes,
this
sir.
study is trying to say that if even this sentinel node is positive, you can avoid doing a ALND
Yes, sir.
and no axillary radiation also.
Yes, sir.
But if you are saying that it is not a micrometastasis, none of the patient in the SLNB received axillary radiation, or some patient received radiation. I think there is a mention about some percentage of patient receiving radiation.
Mm,
In SLNB group, there is no radiation.
In SLND group, there is radiation after the surgery.
No, but you are saying that there is no axillary radiation.
No, actually, it is not mentioned as a axillary radiation.
No, at one point it was saying that there is no because if you give axillary radiation, then it becomes like a MRS trial only.
MRS style. If the patient get axillary radiation with prone position, the patient was not perfect for this study.
Yes. So in this group, mostly the patients were spared of radiation also.
Yes, sir.
Ronit, you like to make any comment?
Sir, in Z11, sir, it is a very good trial published in 2017. It says that we do not have to give radiation to the axilla, but in Amaros, we'll give radiation to the axilla. In the in Z11, the trials excludes any kind of mastectomy because the radiation course involves the whole breast and the axilla. So the Z11 trial excludes any patients undergoing mastectomy, any T3 tumors, all clinically palpable
It is
nodes.
T1T2. It's early breast cancer, only BCS. The whole group is that only.
Yes, sir. So in Z11, we do not give any kind of radiation to the axilla, and also we do not do any kind of axillary lymph node dissection in 1 or 2 SLNB positive tumors.
But there are two, again, in this subgroup analysis, there are some patients in G11 where SLNB, they are showing micrometastasis less than 2 millimeter, and a good number of patients having macrometastasis also. That group also was observed.
So micrometastasis is seen in ALND group, sir.
What about?
Yes, also in SLND group, or macro seen in ALND group.
There is no macrometastasis in the SLNB group. Then it becomes a little different. There should be some macrometastasis in the, because you see, they are all clinically node negative patients.
Yes, sir.
SLNB showing positivity. And in ALND group, you have 136 patients with micrometastasis and remaining around 300 patients with macrometastasis. And they have undergone ALND. But in SLNB group, how many has micrometastasis and how many has macrometastasis? Even in that group, the ALND was not done and axillary radiation was also not given. But at the end, the results are comparable.
Sir, in SLND group, it shows it written that 164 patient having macrometastasis, and there is no mention about the macrometastasis.
Okay. If you want 64 as micrometastasis, 164.
164, sir.
Then remaining will be
probably in Z11 trial, the nodal involvement was 60% has got only one positive nodes and 40% has got micrometastasis only. I have to study it again, but probably 60% has got only one positive node in SLNB and 40% has got micrometastasis.
Yes, you see, if there is micrometastasis, there is every rationality to observe, not giving further treatment. But if there is macrometastasis, we have intention to give the next treatment, either radiation or proceed with ALND. But this study is showing that even if there is macrometastasis, the auxiliary outcome is comparable in both the groups.
Yes.
Yes, sir.
So, Dr. Shakrojit,
Yes, sir.
I have one question. Do you think this Z11 trial is applicable for India?
Mm, no, sir.
Why?
Sir, here the knowledge about the patient follow-up is not as per the protocol. Maximum patient for hello. Hello, sir.
Okay, then
Uh, we can follow this patient. We can follow this patient in.
if you can make a protocol to follow the patient up for 10 years, will it be applicable for India?
No, sir. Maximum patient
Why?
does not
Why?
follow the.
No.
He's saying that follow-up is perfect.
Oh, follow-up is it can be applied for the.
No, see, there are some trials published 1 or 2 years ago that Z11 trial is not applicable for India basically because the mean tumor size, as you can see, the mean tumor size of Z11 trial is more than
5
65% is T1 and 30 to
5 centimeter.
35% is T2. And the
Mhm.
mean tumor size is 2.5 centimeter. And in India, the amount of T1 tumor is less than 10%. The mean is around 5 to 6%. This is one cause. Then the age distribution in USA is more than 60 years. And India,
Yes,
the
sir.
mean age is more or less 46.1 years. And if you see in this trial, the molecular subtypes, they have selected mostly the ER positive tumor, which is around 75 to 80%. But in
Yes, sir.
India, it is reverse. The amount of TNBC and triple negative and basal type of tumors are more or less 35 to 50%. And the nodal burden of India is very much. And in this trial, the treatment offered is only BCS. This trial mandates the whole breast radiation.
Yes, sir. Yes, sir.
Okay, so this trial is more or less not applicable for Indian subpopulation.
If you,
Okay.
Ronit, if you get a subgroup of patient who are fulfilling the criteria of tumor size being less than 5 centimeter.
Yes, so we
if,
can go for
yeah,
this.
yeah. That because what I'm saying is, as a whole, Indian patients are presenting late, more at TNBC. So that is a situation that tumor is more than 5 centimeter. But G11, the tumor size is less than 5 centimeter.
Yes, sir.
So
The mean
that
tumor size
depends
is 2.5 centimeters, sir, in
Yeah.
Z11.
Yeah.
Yes, sir. If the criteria meets, then we can always go for this trial.
But our patients are presenting late, so it's
sir.
difficult to get such a patient population. Dr. Boshak, any comment? Dr. Boshak?
The discussion is very good, and I totally agree with the points you have discussed. And these patients, there is a huge dropout. Out of 400 patients, 100 patients is lost from the follow-up. So, so this is very important. And in India, what you have said is absolutely right. Our patients are larger, and they have classically discussed this T1 and T2, but these are early T2, 2.5 centimeter. But in our average size is around, in government hospital, is around 4 to 5 centimeter. What we see usually, minimum more than 3 centimeter. And there is always a palpable axillary node if you palpate it. So in these cases, you cannot do SLNB. And it is very difficult to follow up our patients because they hover from one institution to another institution. Thank you.
Okay. Mehul? Mehul?
Yes, sir.
Keep the tomorrow's class postponed. Okay? I have
Okay,
not
sir.
been able to prepare. Huh? So,
Okay, sir.
take it, October is final. You publish October list today. Keep my class in November.
Okay.
Okay. Okay. Thank you all.
Thank you, sir.
Thank you.
Thank you. Thank you.
Thank you.
Thank you.
Thank you, sir.
Thank you. Thank you. Thank you.
Thank you. Thank you.
Bye. Bye.